they come out into the public and it sounds like something totally different. As a patient under SHA, there's also the issue of people who have alternate insurance. But now under SHA, I go to hospital and whatever I'm doing, labs, whatever, should all be covered for if I'm going to get a prescription after diagnosis, get medicine, right? But if the facility, because it's almost like an arrears system. You pay, or rather you get the service, and then the facility will then claim the money later, isn't it? Okay.
Sure.
Now, in the event that there's no pool or there's no assurance that you get, then that's why a lot of people are being told today, we can't do it here because we have not received money. That's the truth.
Sure.
That why they're being sent away is because SHA doesn't work here. It works. But the problem is the pool is not available. They've not paid what we've done in the past. And the likelihood of them paying in the future then is dim. So where does this arrangement come? Because the people who are providing the service is the hospital. When I go to hospital, it's not the Ministry of Health. I'm going to get a service. So when you do the triage and all of this, labs, etc., it is the facility that is providing the service. So when you're going to talk about how we're going to fix this and give you 10,000 shillings, why would you not then have the facility there to tell you, okay, sure, we can do this, and with 10,000 bob, we can then offer you dialysis, we can offer you, treatment and procedure. Why would you not bring in the person who is giving you the service?
Very interesting. And apparently I can't answer that question because we are very much willing as providers to be on the table. Our discussion today is how can we make SHA work for Mwananchi? That is a conversation we would very much want to have every day because it is easier for us. It is easy for us to offer service in an environment where these things are working. So, and the reason for our surveys, our mini survey, is to give this word so that we can make this thing work. You mentioned a very good thing. Why are they not paying the hospitals?
Yes.
That's a question that we always ask. And but from our understanding, there are underlying issues. Because for once, to say the truth, SHA has not been able to collect enough money to pay the amount of claims that are being generated.
Okay.
That's one of the reasons.
Are you saying they undercollect?
Yeah, they undercollect. Yeah. They undercollect. In fact, the last amount of money that NHIF collected before they closed, SHA has never attained that.
But we lost 11 billion. I'm just saying, we lost 11 billion the other day. Just the other day.
Yeah.
And before that, we invested 104 billion, the transition from NHIF to SHA. Are you saying that you as the partners, or rather, what was the essence then of transitioning if one, we're not able to offer safeguard? Because I feel we lose the conversation when we start talking about money and figures. I think the focus, in my opinion, ought to be more about the processes, like the pre-authorization. There's a limit on how much SHA will pay for you and have a certain condition and many visits you could make to the hospital. There's also the variation when you go to a higher level of a facility than, a dispensary. I think these are the processes and procedures that we ought to focus on so that you now, as a provider of the service, you're able to come and say, this process makes it difficult for us to meet again the medical care that this person needs. Because payment or no payment, that is the after the provision of the service. But in this process, like the 104 billion that was meant to ensure we have a more streamlined transition. And also there was the FIF, Facility Improvement Fund.
Yes.
Where does what happens? I don't even want to ask about the money, but what is the impact of those resources having been deployed to the facilities?
You've answered a good question. And that's why I said earlier that SHA, almost 2 years in the system, it acts below expectation.
Right.
All those are reasons why it is below expectation. And a number of things. Let's talk about the processes that you have said. We have not been able to iron out the processes. Despite having a 104 billion system,
right,
we've not been able to iron out this system. And you realize that without systems, you can have good outcomes, because garbage in, garbage out. We need to have that conversation, and we are behind schedule, by the way. 2 years is a long time to just be talking about system. This is what we should be doing before even SHA came into place. Now, when the processes are aligned, what happens is that it makes it easy for the patient and for the provider and even to the payer. But when we still have this issue, the processes are not running. We have the pre-authorization that is not going through. We have the amount of claims that are rejected because of systems. Because there are some claims that have been rejected because you are not able to attach a document, yet it is the system that is not providing you the provision to attach. You find a delivery has happened in the hospital, and the only thing that you have to upload is a birth notification and an invoice. But they ask you, we are rejecting this claim because you did not attach a discharge summary. Where would you have attached? So we still have problem with the processes. And this is now